personal privilege. How many people, this is your first chapter meeting? Because I know there's some new folks here. Thank you very much. Two of the folks that raised hands are interns in our office, and thank you very much for attending. And you do introductions, and you go in, and you have to be careful of when you use phrases like, this speaker needs no introduction, or this speaker is a legend in their field, or this speaker has been transformative in their field, because they sound trite and frankly they're overused. But there are times when it's appropriate. When I became program chairman a year ago, I made a list of, okay, who's basically everyone that I know or I've ever worked with or where I've heard a presentation that I'd be interested in hearing them again. There was one name that I put on that list where I went, if I can book Dr. Ken Shine, then I will have had a successful year as a program chairman. This is the one speaker that I really want. And we got him. And it's so appreciated. I don't know if I couldn't list all of the things where Dr. Ken Shine has touched healthcare and improved it. Lots of people touch it. Can you improve it? Institute of Medicine, patient safety, super utilizers, Code Red, 1115 waiver. I'm going to give you credit on that one too, because that was something that also came out of work you did. Changes in medical education. I couldn't cover everything where he has touched it and improved it. If you are a patient or just a human being, and you anyway enact with healthcare in this state, Dr. Ken Shine's work has affected you. And with that, let me just hand it over to Dr. Ken Shine.
Thank you. Thanks, Jim. That was an incredible introduction. If my late mother was here, she would have believed it. But it's a pleasure to be with you. You do really important work in an area that, as I'll emphasize, is of increasing importance to healthcare in Texas and nationally. What Jim has asked me to do, which I propose to do, is to speculate with you a little bit about the direction for healthcare in general in the United States and in Texas, and ultimately how that might affect you in terms of the work that you do. Many of you will be familiar with many aspects of this, and so to a certain extent I'm speaking to a very knowledgeable group, but I thought that an overview of these developments might be useful. It's always a little dangerous talking about the future, and I remember, which dates me, during Richard Nixon's administration, it was said that Nixon, accompanied by his Secretary of State, Henry Kissinger, a Catholic priest, and a hippie. I don't know if any of you remember hippies, the flower children of the West particularly, who were in an airplane flying over the western United States. When they got into real trouble, it turned out they only had 3 parachutes. So Nixon said, I'm the President of the United States, I'm the most powerful leader in the world, I deserve the parachute, and the other 3 agreed. Henry Kissinger said, my intellect is absolutely essential to the future of Western civilization. I've helped to plan foreign policy and to work with China and other great nations, and I deserve the parachute. The priest turned to the hippie, he said, son, I'm 78 years old, I have no family, I've made my peace with God, you take the remaining parachute. The hippie smiled and said, Father, you have nothing to worry about. The smartest man in the world just jumped out of this plane wearing my backpack. So if I jump out of the plane a little bit, you'll understand. The American healthcare, I should indicate that I have a potential conflict of interest. I'm a member of the board of directors of the United Health Group, which includes United Healthcare, Optum, some of you are familiar with Optum, and a number of other companies. So take that into consideration. The American healthcare system is the most expensive in the world by a long shot, where we spend close to 18% of our gross domestic product on health. That's 1.5 to 2 times what the other OECD countries pay. And in fact, we don't get a very good result from that overall. For example, life expectancy in this country ranks only about 24th in the world. There are 23 other countries that have longer life expectancy than we do. If you measure infant mortality, mortality under the age of 5, a whole variety of things, we don't really get value for money given the amount that we spend. But this is also the critical driving force with regard to a lot of the change that has to take place, because we can't afford to continue to spend this kind of money. For several years, the rate of rise mitigated a little bit, probably as a result of the recession in part, partly as a result of increased co-payments, but it's beginning to rise again, and before long it's going to be 20% of GDP. And if you spend that on health, you can't spend it on higher education or public education or roads or a variety of other things. So there have to be some kinds of changes made in this regard. Slide, please. For some reason, I can't get this to... Okay. What are some of the cost drivers associated with why we're so expensive? I would argue that among the most important is fee-for-service. Physicians, hospitals, everybody in the healthcare system gets more by doing more. And doctors find ways to do that in a variety of ways, whether it's to have a lab in the office, whether it's to have their own terminal or cardiogram. And the same thing is true in terms of the way hospitals in general have been organized. The fact that we have a third-party payment system, of course, is an issue because neither the physician nor the patient is directly paying for most of the care. Although, again, the amount of co-payment has been gradually increasing over the last several years, and I anticipate that it's going to continue to increase. Probably 25% of inflation in healthcare is due to technology, things that you have something to do with in terms of cost. And the issue here is not so much whether we want more technology, but whether we use it intelligently and whether we pay for it so that we're not just doing things on the margin. How important is it that an MRI scanner scans in 30 seconds as opposed to 45 seconds? How much you're paying for the additional 15 seconds? How important is it to have another Me Too drug, which is now under patent, and which you can charge a huge amount for, when there are in fact existing drugs which will do essentially the same thing? Celebrex is probably one of the best examples of that in terms of treating arthritis. But the increases in chronic illness in our country also are going to drive costs. It used to be that when I was in training and in practice in the early years, acute heart attacks was an enormous cause of mortality. In fact, now the mortality rate from heart attacks has plummeted, but there are now many more people who have congestive heart failure, who've had some damage to their heart, and it's a chronic illness. And so as the population ages, we see more chronic illness. We still are confronted by fragmented care. In Florida, for example, 10% of Medicare recipients in Florida saw 20 doctors in the previous year. 20 physicians. Can you imagine that? And you wonder why they get mixed up by what drugs they have to take, what the program is, and so forth. And finally, the medical profession will tell you a lot of this is about defensive medicine, that people do things because they're concerned about being sued. If that's the case, then why, when Texas introduced tort reform and malpractice premiums in this state have dropped 65%, we're self-insured in the university, our rates were low to begin with, and we've dropped 65%. It's made no difference in terms of the way in which people order tests. Defensive medicine is an excuse for doing more. I mentioned some of the outcomes. I'm not going to belabor that. But I would want to move to, if you're going to, in fact, do something about costs, what are the kinds of things you're going to do about it? And I would argue that the two fundamental approaches is how you're going to deal with the way healthcare is delivered and how it's reimbursed. Those are the two keys. So what would be some of the characteristics of a healthcare system that is likely to work and how likely are we to get there. First, increasingly the healthcare system is population-based, and it's going to be patient-centered, but in the cost of a population. And I'll describe some of the approaches that are being taken. But this is a very different psychology for physicians who have historically been interested only in one patient and doing everything that patient that could be reasonably done for their health. Now we're going to be talking about physicians caring for populations in which keeping people healthy has a financial incentive. And I'll come back to that. The system is going to have continuity of care 24/7. Consumers want this, whether they're into boutique health care or whether they're into population care. But one has to find a way to provide 24/7 care. And you really can only do that if you provide team care. And I've called this talk 21st Century Care a team sport. Providing continuity of care and providing population care requires a team. There is no way we can succeed with a physician-only centered approach to healthcare. Even though we're opening new medical schools, even though we're expanding medical school slots, we are still going to have shortages in the range of 90 to 140,000 numbers of physicians by 2025. So it's not going to be a physician-centered program in the same way that it has been in the past. It's going to involve a variety of other health professionals, advanced practice nurses, physicians, assistants, nutritionists, social workers, a whole variety of other people, but again, working as a team. And I'll tell you a little bit about some examples of that in a moment. We're going to have to realign the incentives so that you don't get paid only for taking care of a disease, but you get paid for keeping people well, for keeping them out of the hospital, out of the emergency room. Increasingly, you're going to get paid for outcomes rather than for processes. What I mean by outcomes is, for example, if you have a hip or a knee replacement, how quickly can you walk upstairs? It will be quickly measured, and of course it's amazing because patients with successful hip procedures can walk upstairs in a week. The point is that it's not so much the process of care. Now there are a few exceptions to it. Hemoglobin A1C is so tightly connected to diabetes control that it will probably continue to be a process measure. But the number of those are going to be decreasing dramatically. I'll give you some other examples in a moment. Quality measures will continue to grow and expand, and they are going to be key to both the delivery methods and the reimbursement methods. Because as I'll point out to you, if you pay to keep people well, you got to have some quality measures to show that you're doing that. And if you take care of a population and get paid if they stay well, you're going to have to demonstrate to the patients and to the policymakers that you're not making money by doing less. You have to be able to make money by maintaining quality. Well, how do you measure that? Technology will continue to be a major part of what goes on, of course, and increasingly care is going to be evidence-based. The notion that what you do has to have some justification in evidence has been spreading dramatically over the last decade or so. We're still a long way from there because there are many things we don't have any evidence for. But what you're finding is that evidence is being accumulated, and research is now being funded in a number of agencies to find evidence that turns out to be important. Aligning the incentives then become very critical. And let me spend a few minutes on what those incentives are likely to be. In general, reimbursement for health care falls in the spectrum from fee-for-service over the one hand and full capitation on the other hand. Full capitation means that somebody pays some provider X dollars a year to take care of all your needs. Kaiser is an example of a fully capitated system. The guys in the clinic is a fully capitated system. I'm on the board of United. We own practices which currently take care of 3 million people, and by the end of this year we will take care of 4 million people in practices we own. The vast majority of those care is capitated. On the other hand, you can have partial capitation, where it's fee-for-service and capitation. I'll give you an example of that in a moment. The second way in which you can pay for it is by bundling care, by paying for an episode of care, but going beyond just the example of surgery, but the whole episode of care. So Geisinger started bundling care for cardiac surgery. They would provide care for 9 months. So that includes surgery, the post-op period, the rehabilitation period, and so forth. The bundling period can vary. In Europe, they're beginning to bundle care for chronic illness. In Holland, for example, doctors get paid a flat amount to take care of a diabetic for a year. Now again, bundling has the advantage on the one hand that if I'm responsible for your knee surgery, that I want to be able to provide that in such a way that from that flat amount of money, I can make a profit. On the other hand, I've got to be able to demonstrate that I'm making that profit while doing a very good job with your knee. And it's very interesting. In the Baptist Hospital in San Antonio, the surgeons and the hospital had a big junk about bundling care. Who would get what money from the care and how often they'd get it and so forth. The doctors were suspicious that all the hospital wanted to do was to increase its market share. They wouldn't benefit. Turned out they bundled, the market share didn't change at all, but the doctors take home a nice check every month. The profits that come from that. But again, there are quality measures built in to make sure that people are doing well. You're seeing an increase in gain sharing and shared savings. Shared savings, for example, the employee retirement system here in Austin, which has almost 500,000 members, 473,000 members, has a series that are called health homes. And I'll spend a little bit more time on the health homes. That's caring for a population, in this case, 50,000 of their employees, retirees, are in a health home. When you're in a health home, it means that the physician group, the team, is responsible for your care 24/7. That you have an electronic health record, which we'll come back to, which is necessary to provide 24/7 care because of the various members of the team. And in the majority of health homes, they're fee-for-service with a capitated amount. So they began in North Carolina. The capitated amount was small. It was $2.50 a month per patient. But it's grown dramatically in a number of these capitated plans. What happens under those circumstances? It means that if you can keep that population well, you can keep it. It also means you have the flexibility in terms of how you use the capitation. So if you need one more social worker, because that helps a lot, then you can hire them from the capitated fee. If you want to pay the primary care providers more money, you can do it from the capitated fee. I call that a hybrid system, and right now it's the system which is growing the most rapidly. They are hybrid systems with the amount of capitation varying from relatively small amounts to larger amounts. Pay for performance, it has more to do with, well, I should mention, when the retirement system started this program, they did it with a group of physician providers, and now there are millions of dollars going to the physicians who care for that population as part of gain sharing. The way they did it was they said if we can save money, 50% will go to the docs and 50% will go to the retirement system. So this is a common arrangement now to incentivize people to do a better job for care. Pay for performance may be gain sharing, or it may be that you get a certain amount of money if a particular parameter is done very well. The hemoglobin A1C has been determined in a substantial proportion of the population, for example. Pay for performance, again, started in a very interesting way. Pay for performance for hospitals was in the range of 1 to 3% under Medicare. Now, 1% for a hospital is a lot of money. So hospitals were really motivated to do something about that. 1% for a doc is not very much money. So docs didn't respond very well. Now what you're seeing is the pay for performance taking a significantly larger percentage. And I can tell you again, in some of the contracts we have with United, 10% of the physician's payment is based on performance. So we're getting now to the point where people pay attention to that. So paying for performance, gain sharing, and so forth. And then there is also an expansion of activities where first Medicare, now Medicaid, and now some insurance companies won't pay for certain things that go wrong. That if you, in fact, have developed skin ulcers while in the hospital, the insurer or Medicare is not going to pay for the care that's required to deal with those ulcers. Believe me, that has a big impact on whether people do a good job. One other issue that I want to comment on that I've already referred to is that Texas is a state which is short of physicians to begin with. If you look at the national average, and again, you'll see different numbers. It depends on how you measure them. This is patient care physicians. You'll see it direct care physicians. You'll see it hands-on physicians. But the relative numbers are real. For patient care physicians nationally, it's about 263 per 100,000. In Texas, it's 205. In South Texas, it's 107. That will give you some idea what the physician shortage is like in South Texas. Given the birth rate in South Texas, don't think for a minute there's going to be anywhere near enough physicians to provide one-on-one care over an extended period of time, 24/7. Primary care physicians, again, the national average is 100. Texas overall is 79. South Texas, 39. I mean, it's extraordinarily low. We also have shortages in particular places. In this state, for example, the biggest shortage area is psychiatry. We have 58% of the national average of psychiatrists per 100,000. I'll come back to that because of the issue of mental health and particularly the role of technology, telepsychiatry, which has gotten a big boost in this state. We're also short of baccalaureate-trained nurses. The data is very compelling. The mortality in the hospital goes down the higher level of education of the nurses in the hospital. It's been shown in this country, and it's been shown in Canada. As a consequence of that, hospitals, the Texas Medical Center in Houston, if you don't have a baccalaureate degree, it's almost impossible to get a job as a nurse in those hospitals. The hospitals are preferentially hiring baccalaureate nurses. They'll hire advanced practice nurses, and the same thing is happening. We also have in Texas major shortages of pharmacists, dentists, physicians, assistants, and mental health providers, not just docs. One of the developments over the last several years, and Mr. Cooley made reference to this, was the 1115 waiver. And I just want to spend a moment on that because we've learned a fair amount from this waiver. It's a 5-year waiver that expires in 2016. We actually recommended in 2006 that the state get an 1115 waiver. It only took 5 years. 2011, we got the 1115 waiver. It's a waiver for $29 billion over 5 years. It has two portions. Uncompensated care, that is the amount that hospitals have to be reimbursed because they are taking care of people who have no insurance, and DSRIP, which were delivery system reform incentive payments. These were to pay for projects that would improve health care. The principal issue was improving access. So, for example, could you expand the time that your clinic was open? Could you open on weekends? Could you do a variety of other things? Or to improve quality. And as I mentioned before, behavioral health was a big part of it. 400 of the 1,500 projects were in behavioral health. These projects are still ongoing. They're still being evaluated. But they were very important for a couple of reasons. One is they had a number of them using telemedicine. And telemedicine can, in fact, be very effective in a variety of areas. The Texas Medical Association is very much opposed to telemedicine being easily available, frankly. They want a patient to receive care by telemedicine only after there's a face-to-face meeting with a physician. And that's the position they're taking. The medical board has supported that position. The courts have now put a hold on that requirement. And you're going to see a fair amount of legal activity around it. Among the telemedicine activities was telepsychiatry. And if you would ask me before this happened how effective it is to give therapy in terms of behavioral health by television, I would have said, I don't know how you do that. In fact, patients relate very well to providers by television. They communicate well. In fact, many people feel that they're more open than they are sometimes in the office. One can prescribe appropriate medications and even give a certain amount of talk therapy by telepsychiatry. So this is a major development which has come out of the disrupt activities. There are others, and you're going to see these as the data. Unfortunately, it's a 5-year waiver, but many of these projects didn't really get up and running until the second or even the beginning of the third year. So we're only just beginning to see data from them. But telepsychiatry turns to be. So what are some of the opportunities? I've already mentioned health homes. There are now several hundred health homes, well over 300 health homes in Texas. A health home, as I mentioned before, is a group of physicians, usually primary care, but not restricted to that, with a team taking care of a population anywhere from 5,000 to 15 or 20,000 people. In the case of the retirement system, it's 25,000 patients in their 2 health homes. The health home has to operate 24/7. It must have an electronic health record in order to be accredited by the accrediting bodies. It has to have a variety of services. And as I mentioned, it can be funded by capitation or by fee-for-service plus capitation. And it has to measure outcomes that are related to health. So, for example, if it's a health home that involves children, how much time do they lose from school? What kinds of use of the emergency room is required, and so forth. Health homes have been particularly effective in people with chronic illness, who are in fact the main users of care. So we've just seen data from Houston on a health home which involved children with chronic illnesses, asthma, a variety of other disorders. And they stopped the study prematurely because it clearly saved both money and improved quality of life for these kids. We have a project at Galveston where we call frequent flyers. These are people who use the emergency room a lot. And so it started with patients with diabetes, congestive heart failure, and hypertension. Within 2 years, we had reduced ER visits by 60% and hospital days by 50%. Huge savings. The program has expanded, and Blue Cross Blue Shield, about a year and a half ago, has asked the group to take on a group of insured frequent flyers from Blue Cross Blue Shield. We'll see what the data looks like for those folks. But the point is, people who use healthcare a lot are the ones that, you know, the rubric is some 5% of patients account for about 80% of healthcare costs. It's true, depending on the population. So if you can focus your efforts on those people who are high users, then that's a very important way to deal with it. Again, coming back to the data, one of the things that the retirement system found was that it keeps track of emergency room utilization. And it noticed that there was a fair amount of utilization of people with headaches. And so recognizing that headaches was a major problem, they set up a separate program where people could talk to someone without going to the emergency room to deal with headaches. They dropped the emergency room use dramatically of people with headache. The ability to analyze the data literally month by month so they could look at utilization had a major impact on their ability to get the millions of dollars in rebates that they're paying. Accountable care organizations are basically large health homes. I happen not to like the term accountable care organizations. I prefer the concept of collaborative care organizations. But an accountable care organization is much like what a health home does, but for a much larger population and includes hospitals. Health homes don't ordinarily include hospitals. They're physician-driven, but the successful health homes will have a contract with local hospitals in terms of controlling the costs when they need to do hospitalization. Accountable care organizations often have a hospital involved, but not invariably. When accountable care organizations began, hospitals began to hire docs like crazy. And interestingly enough, physicians, in fact, are increasingly working for a hospital or health organization. Last year, 52% of physicians who went into practice either for a hospital or a health system. And right now, about a quarter of all docs work for hospitals or health systems. That trend, in my opinion, is going to continue because, among other things, half of these physicians are women, and they much prefer to have controlled hours. They much prefer to have a controlled schedule. They much prefer not to have to do the paperwork and so forth with regard to billing and collecting and so forth. But the same thing is true with young men, that they also find it attractive to avoid a lot of these kinds of activities. So what's happening now is health homes, we're now seeing bundling. All of my campuses in the UT system bundle one or another things. We bundle everything from, most common bundles are orthopedic, knees, hips. After that comes heart disease. At Southwestern, we bundle the care of cerebral aneurysms, believe it or not, because we see so many cerebral aneurysms at our hospital in Dallas that we know what it costs. And so we can charge a flat rate. It's of interest that MD Anderson has just done a deal with, again, United, on bundling of head and neck cancer. They see enough patients with head and neck cancer that they know what the average cost is for 1 year and 2 years. Now, again, let me emphasize again, it doesn't work unless you can combine it with quality data. So in the case of head and neck cancer, it's not simply whether you get good mortality results, because only about 5%, 6% of people with head and neck cancer die in the first year. The question is, can they eat? Can they speak? Can they swallow? Are they having pain? What is their sense of their quality of life? And so you have to measure all of that so that you can show them you're not skimping when you take care of their cancer. The last thing, on the other hand, it turns out you don't need anywhere near as many MRIs as people have been routinely using for cancer. You don't need them. Imaging is enormously expensive. And it's been a problem for MD Anderson because there's been a big decline in income because they're doing a lot less imaging. That's good for patients, and it's good in terms of controlling costs. I've mentioned gain sharing. Increasingly, there's an emphasis on time and effort reporting so that you can rationally figure out how to better provide care. So that MD Anderson, for example, under Michael Porter's rubric, they know exactly how many minutes are spent for each patient that comes into the clinic by each of the players so that they can design care models that will dramatically increase efficiency. They had a situation in which you had to wait a week or two for many non-invasive ultrasound kinds of studies in their ultrasound lab. They did a time and effort study looking through that, and they found that they could dramatically increase the efficiency. Some of it actually is absurdly simple. One of the things that was happening was they would do the intake of patients in a room where there was an ultrasound machine, instead of using the ultrasound machine to get a test result. Moving the intake elsewhere increased the efficiency by adding a machine. I mean, it's not rocket science until you actually look at it in detail. The waiting time for ultrasound at MD Anderson is now 1 day. I mean, incredible changes taking place. We're also doing much more in the way of systems engineering, applying the principles of industrial engineering to healthcare. And let me give you again a quick example of that. A firm made a lot of money on the way in which trucks move in and out of truck terminals. Companies wanted to increase the efficiency with which trucks came in, unloaded, reloaded, and left. And so they computerized the whole process in such a way that the truck would know exactly what siding that they had to be on to unload. The people who needed to be there to unload it were there with the proper equipment. They had some place to take it, to offload it in an efficient way. And they increased the efficiency in one of the major truck terminals in Canada, which became famous, by 203%. I mean, not just marginal changes, huge changes. That's now been applied to healthcare. So, for example, if you go to the Dell Children's Hospital, when a mother brings in a child for surgery, she's given an ultrasound sensor, and the child's chart has one on it as well. So as soon as they receive that information, there are control boards all over the operating area which can tell you where the child is at any given time. They give the child a number so the mother can tell wherever the child is at any given time. As soon as the child's intake is done, the board shows that the child is ready to go to pre-op. As soon as that signal is sent, the nurse comes to take the child to pre-op, but that also brings in anesthesia, it brings in pharmacy, it brings all the other people that are going to be relevant to that kid. The same thing happens when the child goes to the OR. There's a marvelous control screen, some of you may have seen it, which shows who are the doctors in the room, who are the nurses in the room, what's the equipment that's required, do you need an x-ray equipment, what are the child's allergies, et cetera, et cetera. And as soon as the child is ready for the recovery room, a signal goes to the recovery room to receive the child, but also to the mother to go to a particular place to get debriefed by the surgeon. The surgeon now comes out, knows where the mother is, doesn't have to go look for her, and talks to her about what happened. In the meantime, the cleaning people see that the room is now available, and they go in and clean it. They no longer have a director or a manager of the cleaning people. It's an automatic process. Without going through the other thing is that they can be paged. For example, if a case is running late and they need to reschedule something else, the ER director can simply do it with his or her finger, can move that into a new slot. That automatically pages all of the relevant people, including the nurses, the anesthesiologist, the surgeon, that the case has been moved. And also tells the mother that the case has been moved in terms of her child. And the signal that's sent out can be received on the iPhone of any of the players. So they can do it in the middle of the night. They need to call anesthesia in for an emergency case. They can call in all. The thing that makes it remarkable is if you visit the operating rooms is how quiet it is. Because it used to be filled with the noise of people on the telephone looking for Dr. X or trying to find the mother or whatever. None of that takes place. Those are just examples. I've mentioned outcomes, and there is now an increasing amount of what we call comparative effectiveness research, which is research looking at alternative ways to do things to find out which is most effective. I think it's a worthwhile activity. My principal objection to it is that the Congress said you can't pay on the basis of comparative effectiveness, which is, I found, idiotic, and it's got to change. Clearly, health information technology is going to play a major role in all of these areas, and let me just make a few comments about some of them. One, obviously the electronic health record, I've reiterated, is essential to team care. Without the electronic health record, the person who's called, who has not seen the patient before, is not going to be able to do what he or she needs to do in terms of caring for that patient. No question there are startup problems with electronic health records. We've seen plenty of them. There are far too many companies in the electronic healthcare business, in my view, and I think you're going to see a real shakeout in terms of numbers of those companies over the next several years. I think the federal government failed miserably in their program to not require that there be methodology such that all records could talk to each other. I mean, it's absolutely absurd. I had this argument with David Blumenthal. He pushed back because of the politics, that they were getting tremendous pressure from vendors and so forth not to be held to those kinds of requirements, but it's absolutely silly. Now, you people know far more than I do about ways to create those communications. In the case of the UT system, one of our campuses is this relatively small campus at Tyler that uses Meditech. Our other major campuses are using Epic, and that's a deliberate decision because we've got to be sure that they can talk with each other, and then we've also got to bring our hospital partners into the game in terms of being able to have good communications. But the area, there's no question there's a break-in time, which makes it relatively inefficient. One of the most important clinical developments has been the explosion of the use of MAs, master's level people, who work in physicians, particularly primary care offices, to enter data in the course of the visit. The principal criticism that's made of physicians, of course, is that they sit with their back to the patient, entering stuff on a keyboard. Patients hate it, and physicians hate it. So Slutsky and a number of other people have provided very compelling data that if you have a third party in the room entering the data, the physician now is making face-to-face contact with the patient. The physician also saves himself or herself a lot of time in terms of finishing off the record after the visit, because that's done by the MA or the person who's providing assistance. And what's really interesting about it, it increases the efficiency of the physician's time so that the patient throughput goes up by 1 or 2 patients a day. So that in a primary care practice, you can pay for the cost of the individual by seeing additional patients. And for those of you who want to read something about this, there's a very good article called The Joy of Practice, which is in the Journal of Family Medicine, describing a number of practices that have been doing this, and it's growing more outside of Texas than in Texas, but it's beginning to grow in Texas as well. The second point I want to emphasize is we've talked about population care, and big data is clearly the wave of the future. Some of you may be aware that we have an agreement with IBM to use Watson, the major computer, at MD Anderson. And we started with leukemia because they see so many patients with leukemia. And it was a challenge, but the point is that one can enter huge amounts of data about patients with leukemia into the system, and that the analytics are such that you can very quickly determine, given the patient's tissue diagnosis, their cell typing, all of the minutiae about the nature of their leukemia, what is the currently best therapy, what drug combination or other combination would work for that patient. While it's been used principally in MD Anderson right now, the goal ultimately is to make it available to physicians elsewhere, so that if they enter their patients, they can get the benefit of that data in terms of making therapeutic decisions for the patients in their office. But the point is that once you move to population medicine, you move to real opportunities from the point of view of data collection and data analysis. Many of you have heard the term personalized medicine. More recently, the phrase that's been suggested is precision medicine. And there's a very good article in the New England Journal of Medicine this last week on precision medicine. What's precision medicine? Again, it is tailoring care to an individual, so that if you have to have an anticoagulant, that we know what your enzyme makeup is in terms of metabolizing the relevant drug. If it's Coumadin, then clearly the metabolic pathway determines what the dosage of Coumadin ought to be. If it's methotrexate and you're using that to treat your childhood leukemia, the metabolic rate for the metabolism of methotrexate determines whether the child has his bone marrow wiped out or whether they get a good therapeutic result. Those kinds of data are going to be collected to an increasing extent, and the analytics are actually going to be the biggest challenge. Collecting the data is not so much the issue. I'm sure you're aware. It's coming up with ways to properly store it and properly analyze it. And I think that the emphasis on personalized, perhaps we should call it precision care, will have an impact. People are much more interested in knowing what healthcare costs. And interestingly enough, doctors don't know how much healthcare costs. And hospitals don't know what healthcare costs. People who know what healthcare costs are insurers. And so you now have United and a couple of other firms with programs such that a patient can go on and find what the average cost of a knee replacement would be. Again, depending on where they are and how specific the data is, they can get a pretty good idea or they can get a very general idea. We've been doing bundling of transplantation since the 1980s. Kidney transplants, liver transplants are bundled. So you can go on right now and find out what would cost you to have a kidney transplant at UCLA in Los Angeles, and what the overall cost would be. But what you're going to see now is in situations where you're not ready for bundling, what are all the aggregate costs? Now, obviously you've got to take in a lot of consideration. If you have a knee, the question again is how much physical therapy will you need? And that's going to depend on your overall physical condition and so forth. So one can find ways to put in the risk factors, your age, the questions about your physical capability before you had the hip or the knee, in order to calculate what is it you're likely to have to need. And then can we give you a notion of what the price is going to be? And then can we say that your insurance will provide such and such in the way of copay? Alternatively, what's Medicaid going to pay for it, which will give people increasing amounts of chest pain. So I would say change is inevitable. We've said this, for a long time, that healthcare was going to undergo some fundamental changes. I think we're there. I think the momentum is enormous. One of the signal events of the last few months was the resolution of the SGI, the physician payment method for Medicare, where there had been a formula in place for decades which would have caused physicians to get less and less compensation. The Congress kept kicking the can down the road and only recently passed a law which did away with that whole system and guaranteed payment. But the law is very important because the law says that in addition to doing away with the cuts and putting in only a small increase, 0.5%, that it expects that over the next several years, that a very large proportion of care will be, quote, value-based care. And by value-based care, they mean the things we've been talking about. They mean bundling, they mean pay for performance, they mean gain sharing, they mean 24/7 care, they mean partial capitation, and so forth. The Secretary Burwell, has said that as far as Medicare is concerned, by 2018, she wants 60% of all the Medicare reimbursement to be value-based Medicaid. Value-based is code for what we've been talking about. And all I'm suggesting to you is that in public policy, that's what's happening. In the private sector, that's what's happening. And again, my experience on the United board is that we expect by 2018 that at least 65% of the reimbursement we do in the private sector is value-based. We will be increasing the amount of we will be increasing the amount of gain sharing, the amount of percentage of reimbursement that's based on performance, and so forth. So this is not something theoretical. This is happening, and it's going to happen. Consumers are increasingly going to demand it because they want to know, to a much greater extent than they ever did before, what's it going to cost them, and what's the most effective and efficient way they can get their care. And they're going to be able to get that information. They're going to be able to get information about, in fact, how many people can walk a week after they have their knee or hip replacement, and what it's going to cost. Health information technology, absolutely central to change. None of the things that we're talking about could happen without it. And I would argue that there was a period of time in this country in which groups of physicians wanted to take capitation because it made life so much easier for them. They just would do what they thought was right for the patient and so forth. Problem is they lost their shirts because they didn't have any data. They didn't know what it was going to cost them. They didn't know where the risk was. They didn't know how to lay off risk and so forth. Now, there's an increasing potential source of that kind of data. The reason United is buying practices and why docs want us to buy them is because we can give them the data that allows them to practice and take risks. That's going to happen much more broadly. The division between insurers, hospitals, and physicians is blurring. And hospitals hire docs, they provide care, but they're also going to have to figure out how those docs can make a living, because hospitals lose money often on the docs that they hire without adequate data. And so, again, United, we've now done mega contracts with Dignity Healthcare, with Mayo Clinic, with a variety of others, in which we can use our actuarial capability to help them understand where their risks are and how they're going to deal with the physicians that they hire. So I think it's an exciting time, and I think you guys are well positioned to play a major role in it. Why don't we stop at this point? And we've got 12 minutes for questions. Thank you. Mr. Cooley. I think there's a really good opportunity developing in this regard. We've recently hired David Lakey, whom you know, who knows you and knows us, and has an office in at the UT system, 6th in Colorado. In the next couple of months, the Dell School will announce the recruitment of a nationally recognized individual in public policy who wants to do what you're talking about. I can't publicly give you his name because he has not notified the think tank where he works that he's leaving. But you're going to be impressed. And I believe that there's been enormous communications difficulties. I don't have to tell you about the problem of getting at Medicaid data. And I don't have to tell you the problems when you want to do an analysis. The number of places where the data exists. I mean, we've been struggling with this project on mental health and chronic mental health for some time. And what is there? There's 4 different data sets that we have to try to rationalize in terms of bringing it together. So it's not made it very easy for academics to do the kinds of things that you'd like them to do. On the other hand, I think you're going to be in a good position in this next several months. And I think that David and this new person are going to be able to really energize the whole area. And they are interested in it. Incidentally, one of the things that I think that the department really has to get after is that you have to get after the managed care folks in the Medicaid program to start seriously doing value-based purchasing. I mean, they're the ones who are going to have to do it with regard to the providers, and I think they can if they're incentivized properly. I was very disappointed, I have to say, with the decision in the legislature not to increase the Medicaid reimbursement rates to equal Medicare. That was a real disappointment, but c'est la guerre. Yes.
All right, and actually, we are taking questions, and I just ask that you raise your hand so that we'll pass the mic around this way. The people who are participating in the webinar can also hear the question as well as the answer. I will pass it around. Let me ask the first question first from one of our participants, Louisa, and she is asking, how do you propose to strengthen the protection of patient privacy, which EHRs have put at risk?
I think it's a continuing problem, and there's no simple solution to it. I think that because of the issues of cybersecurity, encryption has gotten much, much better, and I think encryption is going to be a key to the patient privacy issues. But I would want to emphasize to you, keep in mind that I practiced for, I don't know, 40 years, a long time. Paper charts were totally unsafe. People had access to paper charts all over the place. And the notion that appropriately we need to hold electronic health records to a higher standard than paper charts, but we were in a very secure system in terms of information before the electronic health record. Sir.
So we really enjoyed hearing the perspective on more the long-term perspective on population health management and bundled plans from the provider standpoint. And I just wanted to get your perspective, having your foot in both the provider space and the payer space, how that's going to be impacted by the multi-payer private insurance exchange movement in the payer space, where now I may be changing health plans, even insurance companies every year based on my employer's private health exchange.
Yeah, and I think it's a real challenge. I'm a small voice at United for trying to do much more to rationalize the data collection, the quality measures, and so forth that are used by multiple insurance companies. And I've been a little encouraged by the fact that some of the projects we've done on cost, we've been able to get Aetna and Humana to participate with us. But we have a long way to go, and I think it will. I think it'll continue to be challenged, Andrew. I don't have a simple solution for it. I do think that I see the beginnings of some willingness to try to rationalize the way, the nature of the information and how it's used.
In kind of a related vein,
would you just identify yourself?
Yeah, Dave,
I know Andrew, but
Dave Wanzer, JBS International. In a related vein, what's your prediction on what the outcome of King v. Burwell will be and what that might do in terms of both population health and the change trajectory?
Yeah, well, you're all familiar with King versus Burwell. King versus Burwell is a suit that's been brought before the Supreme Court. We should get a ruling by the end of this month, in which it was argued that the language of the Accountable Care Act required that subsidy for insurance premiums could only be provided in states which provided the exchange. That the states where there was a federal exchange, you couldn't use the subsidy. I'm not a lawyer nor an expert on the Supreme Court. I think any reasonable person would believe that the court would not threaten the coverage of whatever it is, 7 or 8 million people, but God knows what that means. There are a number of options. The administration has been playing it very coy. When they have been asked, they say there's no choice because they don't want to give the Supreme Court any room to get off the hook in terms of what they're doing. A number of red states will immediately convert the federal exchange in their state to a state exchange. It's already happening in Pennsylvania, several other states, because these governors don't want to be confronted with hundreds of thousands of people losing their insurance, and these are red states in which they're very worried about the next election and not being accused of throwing people off coverage. So, I think there'll be a real expansion of state. It'll be a change in name only. I mean, it'll be still the federal exchange, but it'll become called the state exchange, and they'll have some personnel doing it. And the feds are preparing to do that. That's a current activity going on, which they won't talk about in terms of the public relations aspect of it. There are a number of other options with regard to how one might deal with it. And all I can say is that United has evaluated a number of positions we would take that would try to bridge the gap, but at the present time those are proprietary, unfortunately, so I can't really talk about them. All I can say is there's lots of people figuring out what to do. Other comments?
So we have time for one more question.
Boy, she's tough.
Wayne Caswell, Modern Health Talk. The question's related to some of the things you talked about, transparency and systems engineering, and it's also related to the way corporate businesses run when they come to a make versus buy decision. So a health organization, whether it's a private practice or a medical home or a ACO, they may not be making a make versus buy decision. I was wondering if you might comment on medical tourism as a buy type of approach. If the insurer determines that I can get better outcomes for significantly less cost across town or across state lines or even international borders, would it not make sense for the physician to recommend going here for your knee surgery rather than try to have orthopedic surgeon here in my practice?
The answer is yes, it would. Moreover, as you well know, what you're starting to see now are corporations doing specific deals with providers. For example, there's a big deal. Walgreens has got a deal for its employees where the company makes a deal with the Cleveland Clinic to do the bypass surgery for that. And it's cheaper for them to fly you to Cleveland, have you had the surgery there. The results are so good that your overall medical costs are controlled, and the incremental cost of flying you there pales in terms of the dramatic improvement in other costs. So there are a variety of schemes that are going to offer that. And of course, the media has been filled with India and people going overseas. That I see as much less part of the solution. But I do think big employers, and I think employers are going to push in the direction you're talking about. Once the cost of things become public information, it's going to be very hard for people not to use that to make good economic decisions. Thank you very much.
Thank you so much. And for those who had additional questions, because I saw a lot of hands that went up, if you still want Dr. Shine to go ahead and answer them, please email me. You can do that at austin.communications@himchapter.org, and I'll make sure he receives the questions and we can get them answered. We'll probably also post them on our LinkedIn, so you can always go to our group page and ask questions there as well.
Thank you so much. Dr. Shine, thank you. Thank you. Just a token of our appreciation, the only thing I can say is be sure you encrypt the USB in there.
Oh.
If you put your personal health record.
Oh, okay. Thank you very much.
Everybody, thank you so much for your time. Please be sure on the back of your agenda is an evaluation.